Okay, so now we're going to talk about permanent methods of contraception. For women, that's going to be tubal ligation or occlusion. That means the fallopian tubes are cut, tied, cauterized, occluded, or some combination of those. In that surgery, this can be done laparoscopically. It also is sometimes done after a C-section before closure. This can be done laparoscopically. A sample of each tube is sent to the pathology lab. And that's because when you're in there, all of the structures, there's lots of structures that appear tube-like and everything's kind of the same color, more or less. And so it's possible to actually have pieces of some connective tissue and think that they've cut the tubes. And so they send those tube samples to pathology for confirmation. There's some legal issues surrounding tubal ligation. Permanent sterilization has been used for eugenics many different times in our country's history. People who were considered not worthy of reproduction have been sterilized without their knowledge or consent. That has been done to people with mental illness, to people with developmental disorders, to people with other disabilities. It has also been done to people based on racial groups. So it has been done to Black women and to Native women. And I personally know an immigrant that this was done to in the 80s. This is not a long time ago in history. Don't tell me how far the 80s are back, but this has been done without the knowledge or consent of the person in a lot of cases. And how does that happen? That happens because people are lied to about what's happening. They have a C-section and their tubes are tied during that case and they're not aware of it, or they're told they're being given one treatment and they're given something else. So because of the legal issues with coerced or hidden or secret sterilizations, there are some strong legal issues surrounding it. And one of the things is that if Medicaid will pay, if Medicaid is going to be paying for that tubal ligation, then the patient has to have signed a consent form at least 30 days in advance. And that's so that that's a protection for the patient, so that the patient cannot be coerced to sign that consent when they're in the hospital in labor. Because another group of people who have had tubals performed either by coercion or without their knowledge are low-income women, women who are receiving Medicaid or are low income, because there are people who believe that they don't need to reproduce. Whether that is your belief or not, you don't get to impose it on other people. So if Medicaid is going to pay for a ligation, that consent has to be in place for 30 days. You're going to see this come up in your labor and delivery rotations, most likely, because there are times when someone maybe is in preterm labor and they plan for this to be their last pregnancy, and they want a tubal ligation after delivery, but they cannot get it because it hasn't been 30 days since they signed their consent, or because they haven't signed their consent yet. It's not time yet. So that consent has to be in place for 30 days for Medicaid to pay. Sterilizing minors and mentally incompetent patients is restricted and may require approval of the court-appointed board, and that's because of past abuses. Tubal ligation can be performed immediately postpartum or post-abortion, and frequently is done in the immediate postpartum. The risk and drawbacks: it is a surgical procedure. There's risk of hemorrhage. That's pretty minimal, but they can actually nick an artery or a vein. So there is a risk of bleeding. There's risk of infection. There's a risk of an adverse reaction to anesthesia. It's not uncommon for women who've had a tubal ligation to complain of an increase in dysmenorrhea. They don't know what the mechanism of that is, but it's a common enough complaint that it's kind of on the radar. Sometimes women don't understand that tubal ligation is permanent. That's one of the things that needs to be covered in the consent. And as a nurse, if the patient indicates to you that they think a tubal ligation is reversible, it's something that needs to be clarified with the patient. They are doing reanastomosis surgeries to reverse tubal ligation, but that is not guaranteed. It is still possible for that not to happen, okay? Tubal ligation is considered permanent. It's very effective. The failure rate is 0.5%. And for tubal ligation to fail, there are a few people that actually have an additional fallopian tube that gets missed, so they might have an extra tube. Or sometimes the ends of those tubes manage to find each other and regrow. Or if an ovum is released into the abdominal cavity, sometimes it finds its way into an open tube into the uterus. So failure rate is low, but it does still occasionally happen. Reanastomosis can be done, but it's not guaranteed. Okay. Now for men, there's vasectomy. Let's first look at an image of what tubal ligation looks like. And this is just a drawing, but the fallopian tubes may be banded, they may be tied and cut, they may be cauterized, they may be clipped. So there's different ways that the goal is just to obstruct an ovum from getting through that fallopian tube, getting fertilized, getting into the uterus, okay? So now we're gonna look at vasectomy. The vas deferens is cut, tied, occluded, cauterized, or some combination of those. The thing with vasectomy is that sperm that are already in storage actually have to be cleared out after surgery. So a barrier method has to be used until a clear semen analysis is obtained. Okay. The risk and drawbacks, complications are rare. It's a lower risk than tubal ligation. There's a possibility of anesthesia reaction, adverse reaction, bleeding, hematoma, infection, epididymitis, granuloma. Some men complain of painful ejaculation after a vasectomy. And again, we need to make sure that that person knows vasectomy is considered a permanent form of contraception, and that yes, they are doing reanastomosis surgery, but we cannot consider it a temporary reversible form of contraception just because reanastomosis is not guaranteed to work. Failure rate with that should be typical use on the top, perfect use on the bottom. Failure rate with perfect use is 0.1%, typical use is 0.15%, and typical use would be not going back and getting those cleared sperm counts. So after a vasectomy, men should still use a barrier method consistently until they've got clear sperm counts. Okay, so let's look at what that looks like. Okay. So testes, here's the vas deferens, and here's where that sperm would be stored. And so once this is cut, cauterized, whatever's going to be done to obstruct the flow of just sperm, that just stops sperm from getting in, it does not affect, vasectomy does not typically affect the quantity of semen. It just takes the sperm out, because remember, sperm is a very, very low percentage of what's of the composition of semen. It's a low part of the volume. So once this is interrupted, we still have sperm stored. And so until this is cleared, that vasectomy is not considered complete. Okay, so that's sterilization. The last recording for this lecture is going to be a challenging one, but it is one you need to listen to. We're going to talk about termination of pregnancy. And it is a difficult one, especially where we live. So we'll come back for the last one.